Hi, I'm Vibeke Strand, and I'm going to be talking to you about small molecular immunomodulators. The learning objectives are to understand the similarities and differences between these oral small molecules, which promise to be very exciting in rheumatology, and to compare and contrast their safety profiles as we know them today. There are presently 5 of them that we know about. The one that is currently of most interest is Tofacitinib, which is a JAK3/1/2 inhibitor from Pfizer. The phase 3 trials have been completed, and the NDA, the new drug application, will be submitted to FDA. And these were several ACR abstracts, a total of 12 in all this year. The next product is the Vertex VX509, which is a JAK3 inhibitor, and it had just completed a phase 2A proof of concept trial, which was also presented at ACR. Another one is Ruxolitinib, or Jakafi, which is a JAK1/2 inhibitor developed by Incyte and co-licensed with Lilly that's in phase 3 trials in RA, but it was just approved in November for treatment of myelofibrosis, and thus it has a trade name. And finally, there's GLPG0634, which is JAK1/2 inhibitor from Galapagos. It's in early trials. And there's fostamatinib, which is a Syk kinase inhibitor from Rigel and AstraZeneca, which is in phase 3 trials, and we'll cover 2 of the abstracts from ACR. Now, the phase 3 trials in RA for Tofacitinib include 5 of them, and 4 of these were discussed at ACR. All of them compared Tofacitinib 5 or 10 milligrams BID with placebo, with rescue of placebo non-responders at month 3 and rescue of all placebo patients at month 6. And depending on the study, the primary endpoint was at month 3 or 6. So there was oral solo, which was a monotherapy study, and this was presented at ACR and EULAR, but not at this year's ACR. Then there was oral sync, which was Tofacitinib versus placebo in DMARD-IR patients, and this was a combination study. So we were looking now at Tofacitinib with failed DMARD background therapy. Then there's oral standard, and standard compared Tofacitinib versus adalimumab versus placebo in methotrexate incomplete responders. Oral scan then looked at Tofacitinib versus placebo in methotrexate IR patients for radiographic endpoints at month 6 and month 12. And finally, oral step, which looked at Tofacitinib versus placebo in TNF incomplete responders. So this is the study of oral standard, which is Tofacitinib 5 or 10 versus adalimumab. There was not a statistical comparison to adalimumab, but numerically one can see that, in fact, they do perform better than adalimumab for ACR 20, 50, 70, and DAS28 low disease activity. This was a 12-month study, but I'm showing you the 6-month endpoints, at which point all of placebo was rescued. And with most of these studies, you'll see that the ACR 20 is the primary endpoint either at month 3 or 6. The change in HAQ disability index is always at month 3, and the DAS28 less than 2.6 is at month 6. And in this study, as with all the others I'll show you, the HAQ disability index was statistically significantly improved versus placebo. And in this study, but not true for oral solo, we had the endpoint at 3 months. Patients did not reach DAS remission at 3 months in that study, but in this study at 6 months, they definitely did. The next study is oral step, and here we're looking at patients who have failed at least one TNF inhibitor. They're on background methotrexate, and these are 5 and 10 Tofacitinib BID versus placebo. Again, the primary endpoint was met, and this was at 3 months for all of the components. And you can see it's highly statistically significant. And as is generally true, the 10 is a little bit better than the 5, but as you can see in the ACR of 70 scores, this was not true. Now, oral sync was in DMARD-IR patients, and we saw the primary outcomes of this at EULAR this year. So I'm showing you now the patient-reported outcomes from this study, and they included global disease activity, pain, and HAQ disability index as components of the ACR criteria, but also the SF36, which I will show you in a minute, the FACIT fatigue score, and the MOS sleep. So I'm showing you a spidergram of the SF36, and if you look up at 12 o'clock on the figure, that's physical function, And you go clockwise, it's role physical, bodily pain, general health perceptions. Those are considered to be the physical domains of the SF-36. At 6 o'clock is vitality, then social function, role, emotional, and mental health index, and these are considered to be the mental domains of the SF-36. Each of the grid lines represents 10 points. The higher the score, the better. And MCID, as we know it, is 5 points, so about half of these grid lines. So when I show you the first polygon, which is yellow, these are the weighted baseline for the entire protocol population. And then I add the outer polygon, which is blue, and those are the age and gender-matched norms from the U.S. that are specific to this protocol population. So you can consider them as a benchmark for where patients should be were they not to have been impacted by rheumatoid arthritis. Next, I'm showing you improvement in the placebo group, which is the gray polygon. And now I'm showing you the improvement in the tofacitinib 5 milligram BID group, which is red, and as you can see is statistically significant in 7 of the 8 domains. PCS score and MCS scores were both statistically significant with 5 milligrams. And then when we go to the 10 milligram, which is the outer blue polygon, you can see that all the domains and, well, the PCS and MCS scores were statistically significant. If we looked across all the different PROs and data that I'm not showing you, in fact, somewhere between 60 and 75% of patients reported improvements that met or exceeded MCID, and this meant that we had numbers needed to treat on the order of 4 to 5 with a 10 milligram and 5 to 6 with a 5 milligram dose group, and those are very impressive numbers needed to treat. Next, we'll move on to the radiographic progression from oral scan, and I'm showing you the month 6 results, and as you can see, they're statistically significant for the tofacitinib 10, but not for the tofacitinib 5, although the differences are numerically large. In part, this may well be due to very low placebo progression. As you can see, the change in total sharp score in placebo was only 0.47 over 6 months period of time. We can illustrate this a little bit better in the next slide. If you look first on the right-hand side, the cumulative probability plot, you can see that actually the tofacitinib 5 and 10 look very similar to each other, but in fact there are a little bit more progressors in the 5, and that could be almost enough to lose statistical significance. On the other side, however, we have the percentage of subjects who had scores of 0 or less than 0, or totally less than 0.5, meaning that they had not progressed in their total sharp score. You can see that it's 89% and 87% in the 5 and 10 milligram dose group at 6 months, so they were not different, and both statistically significant, and this was similarly true at month 12. So we certainly have data that says that both doses are effective, although the statistical significance for the primary endpoint, the mean change, was not met. Now let me turn to safety very quickly. We're looking at the long-term extension data, and this is pooled long-term extension from both phase 2 and phase 3, where patients continued on either tofacitinib 5 or 10 milligrams BID, and background DMARDs could be adjusted. And we're looking here at the events per 100 patient years for serious adverse events, for discontinuations due to adverse events, for serious infection events. And the numbers are considerably similar to what we've seen with other databases. And more importantly, what you can see in the lower part of the figure is that there are few patients who have hemoglobin drops. There are relatively few patients who have significant elevations in AST or ALT. There are almost no patients who have an absolute neutrophil count of less than 500. In fact, there are none. And there are a rare number of patients who have creatinine increases that go above 50%, 1.9. This is unexplained, but may well be a JAK3 effect on renal function. Moving to the left side, we're looking at the total cholesterol. And as you can see, we're comparing the 5 and the 10 and the all tofacitinib groups. And they remain elevated from baseline of the primary study, but they do not continue to go up over time. And we know from the EULAR abstract that using a statin immediately abrogates these elevations. Finally, talking about infections and deaths, which have been of some interest in the phase 3 studies and also now including the long-term extension, this is the pooled data from phase 3, and then over on the right column, the long-term extension. In the deaths in phase 3, there were a total of 12, and you could see the causes. In the long-term extension, there were 20, and you can see the causes, and no predominant cause really is evident other than perhaps infections. We do have infections, and they are increased in men, those who are over 65, and typically with glucocorticoid use, as we've seen with other databases and TNF inhibitors. But the rates are really not different for infectious adverse events between monotherapy or background DMARD use. The serious infection rate in phase 3 was similar between Tofacitinib 5 and 10, although in the long-term extension, the Tofacitinib 10 had more events. Overall, there were 20 patients with opportunistic infections, of which 10 were TB. I remind you that these studies were done worldwide, including Korea, China, India, South America. And there is herpes zoster in this database, and we see it on a rate of about 4 to 5 events per 100 patient years. It decreases over time, and I am aware of only one case which disseminated. So overall, the safety conclusions for Tofacitinib indicate that there are increases in ALT and AST that are similar to adalimumab, but they're much more prominent with background DMARD therapy and not really evident when you use Tofacitinib in monotherapy. Dose-dependent decreases in mean neutrophil counts, but there was no neutropenia, less than 500. There are significant increases in LDLs as well as HDLs and total cholesterol, which may be a sign of treatment of inflammation, but certainly can be abrogated by statin therapy. There are idiosyncratic increases in serum creatinine, which are unexplained. There are no significant changes in blood pressure, and there doesn't appear to be a dose response for infections, opportunistic infections, or herpes zoster, and it doesn't appear to be a dose response either for clinical responses. So it'll be interesting to understand how we will use this product. Now I'll move quickly to the Vertex product, which is an oral JAK3 inhibitor, and you can see from this phase 2B or 2A proof of concept study that statistically significant improvements with the 3 doses for ACR 20, 50, and 70, and also for the DAS 28. Serious infections were a little bit higher in the Vertex dose group. There were 2 deaths and none in placebo. These are small numbers of patients on the order of 40 per treatment group. There were increased LFT elevations, and there were also changes in serum creatinine on the order of perhaps a similar type as we may have been seeing with the Pfizer product. And next I want to move on to fostamatinib, the Syk kinase inhibitor. This is data from the phase 2 RCTs, and this was the methotrexate IR population at 6 months. And you can see the high dose of fostamatinib, which was 100 milligrams BID, shows significant improvements in patient global and pain in the PCS and of the SF-36 and the FACIT fatigue. And you can see on the right-hand side that the improvements with HAQ Disability Index well exceeded MCID. And so we know that the 100 milligram dose group does, in fact, give you very nice results with patient-reported outcomes. There was also a summary of the long-term safety from the phase 2 trials. Remember, there were 2 trials, one in methotrexate IR and another one in TNF IR patients, all of whom were on background DMARDs. And you can see that there are more events for certain things. There's essentially, the deaths were actually fewer in the fostamatinib, but overall numbers were higher because we have very low exposure in placebo. Serious infections were not different. Upper respiratory infections were not different. Diarrhea was different. Diarrhea was more common. Also, blood pressure elevations were more common, particularly if you look at the higher ones, but it was also true for the 160 over 100. And the LFT elevations were higher, and particularly those over 3 times upper limits of normal. So basically, this product is characterized by hypertension. In fact, we know that about 11% of placebo subjects developed hypertension in the first 6 months of the open-label extension when they received active therapy. The GI adverse events are the diarrhea, but also abdominal pain and LFT elevation. So this product is a little bit different from the JAK inhibitors insofar as we know data, remembering these are only phase 2 data. So if you want to compare the safety profiles of these products, you can look at this slide where we've seen that infection has been reported with all of them. I'm going back to the ruxolitinib JAK1/2 study, which was an early phase 2A study from EULAR several years ago. We have that data. So infections are common to all of them. Opportunistic infections have been reported with the JAK1/2 and the JAK3/1/2. Herpes zoster, as I mentioned to you before. Neutropenia has been reported, although very few cases, with the Vertex product, and also fostamatinib. Elevated lipids are common to 3 of them, but not to fostamatinib. Elevated LFTs are common to all of them. Abdominal pain and diarrhea, hypertension and vertigo appear to be more associated with fostamatinib, headache with ruxolitinib, and rarely we've seen creatinine elevations. So I hope that this has been a helpful summary to you of what promises to be some very exciting oral molecules that may well be the new DMARDs of the future in rheumatoid arthritis, and look also for them in some of our other arthritides. Thank you very much.